Hi everybody, Ziv Simon here. Welcome to this video. And in the previous one, I showed you a case where a patient presented with a mucogingival defect. I hope this was very clear. And just to recap a little bit, a mucogingival defect is when you have limited to no attaching keratinized tissue, mostly mucosa, and you're probing into attachment. This particular case also had a frenum pull, a mucosal pull. And at the end of the video, I told you that this patient did not go for the treatment that I suggested, which was a free gingival graft to improve the attaching keratinized tissue. So if you didn't watch this video, go back and watch part 1. The same patient made an appointment for me to observe, and when I examined the patient, he actually mentioned that there's a lot of pain. He felt his lymph nodes were swollen. He felt some mobility on the tooth, and I was amazed to see that in 4 weeks, this patient developed a periodontal abscess with suppuration, with mobility pain, and all the clinical signs of an infection. So this is really maybe an extreme example, but it does happen every once in a while when a mucogingival defect goes untreated through the mucosal pull, through the looseness of the tissue. That allows for a relatively easy path of infection to occur from a coronal apical direction, and that's basically the mechanism of the formation of a periodontal abscess. Of course, this patient now is very motivated to move forward with treatment, and he would like to sign up for a free gingival graft. Unfortunately, this is not possible at the moment because the first step is to treat the infection. And the simplest way to treat a periodontal abscess is initially to prescribe systemic antibiotics and see the patient 2 to 3 days later when the infection has subsided, and then scale in root plane, perhaps place a rest in. And really the goal is to treat the abscess first, make sure that it healed, and only then move forward with a free gingival graft. And that's exactly what I did. The infection subsided after 2 to 3 weeks. The patient was able to go on a trip, and I told him, make sure that you're coming back after the trip so we can move forward with the graft procedure. And he did come back, and he was very, very happy. And then he asked me a question that really amazed me. He asked me, Doc, how much time do I have? How long can I sit on that? And that's a true story. So to summarize, when you're seeing patients with mucogingival defects, meaning there's minimal or no attaching keratinized tissue, your patients are at risk to develop further recession, greater mucogingival problems also in the adjacent teeth, develop infections and attachment loss, which is not a good thing. The best solution that I found that works close to 100% is a free gingival graft. You're improving the zone of attaching keratinized tissue. You're improving the overall health of the area. Maintenance is easier, and all in all, you get better periodontal stability. I hope you found this video useful. Feel free to share it with other dentists. I hope that you have a little bit more understanding about mucogingival defects when patients with this problem present to your office. I'll see you in the next video. This is Dr. Ziv Simon from Surgical Master.